Hello and welcome to iStream Ophthalmology, learning ophthalmology made simple by Dr. K. Suresh. Today we are going to learn about hypermetropia, basics to advanced. So what is hypermetropia? Hypermetropia or long-sightedness is a condition where parallel rays of light gets focused behind the retina. It can be because of problem with the cornea, the lens, or positioning of the retina. So let's see what are the reasons. So when it comes to etiology, hypermetropia can be congenital or acquired. Under congenital, it can be because of conditions like nanophthalmos, microphthalmos, microcornea, etc. And acquired, there are primary and secondary reasons. Under primary, it is more due to the structural causes like changes in the axial length, the curvature, index, and position of the lens. Whereas in secondary, we have reasons like aphakia, ectopia lentis, or overcorrection of myopia. Now let's see each and every condition separately. Axial hypermetropia. So what is axial hypermetropia? As I already told you, this is the cornea and we have the lens and we have the retina. Normally what happens, parallel rays of light are converged by the cornea, again by the lens onto the retina. Now imagine a condition where the retina is slightly anterior. Instead of position A, it is in position B. So what happens, because of the shortening of the axial length, the rays of light are now focused behind the retina, and such a cause of hypermetropia because of axial length shortening is known as axial hypermetropia. 1 millimeter of shortening of the axial length of the eye will result in around 3 diopters of hypermetropia. Now at birth, the eye is normally small. So such a kind of hypermetropia which is seen at birth is known as physiological. But sometimes this axial shortening can happen because of some tumor which is pressing from behind or inflammation, and such a reason for change in the axial length and resulting hypermetropia is known as a pathological axial hypermetropia. Changes can also happen in the curvature of the cornea and lens. The cornea can be a little more flat instead of being curved, or the lens curvature can also be a little flat. So these reasons can again lead to the rays of light not being focused on the retina, and such a reason where this happens because of the change in the curvature of the cornea or lens is known as curvatural hypermetropia. 1 millimeter increase in radius of curvature of the cornea results in around 6 diopters of hypermetropia. As I already told you, it is not only the curvature of the lens or the curvature of the cornea, the refractive index also matters. A change in the refractive index of the lens can alter the amount of converging power the lens has. So when the rays of light fall on the lens sometimes is not able to focus it on the retina because of the refractive index change in the lens. This can happen physiologically in old age or pathologically when a patient is diabetic and is not under control. So such a cause of hypermetropia resulting because of a change in the refractive index of the lens is known as index hypermetropia. Sometimes the lens might be displaced posteriorly. It can be congenital or acquired. Because of this, again, the rays are not focused on the retina and may be focused behind the retina. Such a cause of hypermetropia happening because of a change in the position of the lens is known as positional hypermetropia. Now all these things can happen secondary to either surgery or trauma. For example, aphakia leading to because of surgery or trauma, or consecutive hypermetropia, that is where overcorrection of myopia or incorrect IOL power has been put in the eye, leading to improper focusing on the retina. Such reasons are the cause for secondary hypermetropia. Now, as I told you, the main reasons are congenital and acquired. So congenital, the same axial, curvature, physiological, positional, all can occur. For example, axial length, change in the axial length can happen because of microphthalmos. Change in the curvature can happen because of cornea plana. As I told you, it can be physiological birth. Ectopia lentis can cause a positional kind of hypermetropia. So congenital can be a combination or can occur separately, and this happening at birth is known as congenital hypermetropia. Now let's see what are the clinical types of hypermetropia. Clinically, it is divided into three: simple, pathological, and functional. So what is simple hypermetropia? Simple hypermetropia results from normal variations in the development of eye, which include changes in the axial and curvature of the eye, leading to axial and curvatural hypermetropia. Pathological hypermetropia happens where the changes that causes hypermetropia doesn't fall within the limits of biological variation. So it can be acquired because of decreased curvature of the outer lens fibers, like in old age, cortical sclerosis because of lenticular changes, positional hypermetropia because of trauma, aphakia, and consecutive hypermetropia because of overcorrection of myopia. Okay. Now let's see what is functional hypermetropia. Sometimes all the structural parts of the eye will be normal, but the paralysis of accommodation, we have to understand that accommodation plays an important part in converging the light rays onto the retina. So the paralysis of accommodation, which happens because of nerve palsies, third nerve palsy or internal ophthalmoplegia, can cause hypermetropia, and such a type of hypermetropia is known as functional hypermetropia. Now let's see how this can be graded. The American Optometric Association has graded hypermetropia into low hypermetropia, moderate hypermetropia, and high hypermetropia. So low hypermetropia is around plus or less than or equal to 2 diopters. Moderate hypermetropia is more than 2 diopters to 5 diopters, and high hypermetropia is anything greater than 5 diopters. So having seen all the reasons for hypermetropia, now let's see what are the components of hypermetropia. Hypermetropia has three main components. Total hypermetropia, which is the sum of all the causes of hypermetropia. Total hypermetropia is further divided into latent hypermetropia and manifest hypermetropia. Manifest hypermetropia has subsets, basically facultative hypermetropia and absolute hypermetropia. I will talk about each and every component separately. So what is total hypermetropia? It is the total amount of hypermetropia which is estimated after complete cycloplegia with atropine. So when a patient comes to us, we have given them atropine, completely paralyze the ciliary muscles, and when we do a refraction, the power at which the patient reads 6/6 with cycloplegia. This is total hypermetropia, and this can be further divided into latent and manifest. And as I told you, manifest again has absolute and facultative. Okay, let's see each component individually. So what is latent hypermetropia? So latent hypermetropia is because of the inherent tone of the ciliary muscle. Normally it is around 1 diopters, but it is high in children, and slowly as we age, because of loss of tone of the ciliary muscle, the amount of latent hypermetropia keeps on decreasing. And how do we find this latent hypermetropia? As I told you, total hypermetropia is equal to latent plus manifest. So to find out latent hypermetropia, we have to deduct the manifest hypermetropia from total hypermetropia to find out what is the latent hypermetropia. So what is manifest hypermetropia? So manifest hypermetropia is that part of hypermetropia that cannot be corrected by the ciliary muscle tone. Okay. So how do we find out? It is nothing but the strongest plus lens with which a patient sees 6/6 without cycloplegia. It is very important because we have already found out that what is total hypermetropia. Total hypermetropia, what is that? It is the lens with which a patient sees 6/6 with cycloplegia, and manifest hypermetropia is the strongest lens with which a patient sees 6/6 without cycloplegia. Without cycloplegia, strongest lens. Okay. Now, if there is a strongest lens with which a patient can see 6/6, there will also be a weakest lens. Correct. So the weakest lens with which a patient can see 6/6 without cycloplegia is known as absolute hypermetropia. That is the component of hypermetropia that cannot be corrected by the patient's accommodative effort, and it is equal to the weakest lens with which a patient sees 6/6 without cycloplegia. So we have a strongest lens, we have the weakest lens. So when we subtract the power of the strongest lens from the weakest lens, we subtract the weakest lens from the strongest lens, we get what is known as the facultative hypermetropia. So facultative hypermetropia is that component which is corrected by the accommodative effort of the patient. It is obtained by deducting the weakest power plus lens with which a patient sees 6/6 from the strongest power plus lens with which a patient sees 6/6. Nothing but the same thing which I have just explained, so that we get what is known as facultative hypermetropia. So manifest hypermetropia is the strongest lens without cycloplegia, and weakest lens with which 6/6 is absolute hypermetropia, and deducting the weakest from the strongest will give you the facultative hypermetropia. We will do some exercises using all these formulas so that we can remember. So a summary of the components. What are all the components of hypermetropia? One is total hypermetropia. As I already told you, it is the plus lens with which a patient is 6/6 after cycloplegia. Okay. Now comes manifest. Here, important thing is the strongest plus lens. Patients is 6/6 are the best corrected visual acuity without cycloplegia. These three things are important. The strongest plus lens, best vision or 6/6 without cycloplegia. Then comes absolute hypermetropia, which is nothing but the weakest plus lens without cycloplegia. The patient sees 6/6. Now, deducting the weakest lens from the strongest lens will give you what is known as the facultative hypermetropia. And What is latent hypermetropia? You deduct the manifest hypermetropia from the total hypermetropia to get what is known as the latent hypermetropia. So this is the gist of all the components of hypermetropia. Now let's see a case scenario. We have a patient whose unaided vision is 6 by 36. The patient can read 6 by 6 with plus 1.5 diopters. Okay, so we have a weakest lens which is 1.5 diopters. Okay, then the patient is also able to read 6 by 6 with plus 2. That makes it the strongest lens with which a patient can see 6 and both of this without cycloplegia. Okay, now the patient underwent cycloplegic refraction which revealed an error of plus 3.75. So anything after cycloplegia gives us the total hypermetropia, which is nothing but plus 3.75 diopters. So we have the total hypermetropia, which is 3.75 diopters. Now what did we learn now? The weakest power lens without cycloplegia with which a patient sees 6 is nothing but absolute hypermetropia. So this is our absolute hypermetropia. And again, we also read that the strongest plus lens with which a patient sees 6 is manifest hypermetropia. So this is our manifest hypermetropia. So we have total hypermetropia, we have manifest hypermetropia, we have absolute hypermetropia. And we saw that deducting the weakest power from the strongest power will give us the facultative. So how do we find facultative hypermetropia? It's nothing but plus 2 minus 1.5, which will give us plus 0.5 diopters. So this is our facultative hypermetropia. So facultative hypermetropia is manifest minus absolute, and here it is plus 2 minus 1.5, which will give us 0.5 diopters. Total we have already found out that it is 3.75. Now how do we find out latent? Latent hypermetropia is nothing but total minus manifest. So here what is the total? Total is 3.75 diopters minus manifest, which is nothing but 2.00 diopters, which gives us plus 1.75 diopters. So 1 plus 1.75 diopters is our latent hypermetropia. So you can try to do many such case scenarios, and so that we will be more easy for us to calculate. Okay, so keep doing such exercises to get acquainted with each and every component of hypermetropia. Now let's see what are all the normal age variations. At birth we have around plus 2 to plus 3 hypermetropia, and by the age of 5 to 7 years the child becomes emmetropic. After 50 years of age, the tendency of the hypermetropia is always there even for a normal person. Why is that? Because there is a decrease in the tone of ciliary muscle and there is a decrease in the accommodative power of the eye. So what happens? The latent hypermetropia slowly becomes manifest because we are losing our accommodative power, and more amount of facultative hypermetropia slowly becomes absolute. Okay, this is because of the ciliary muscle tone is gone, and this is because of loss of accommodation with the age. So facultative hypermetropia becomes absolute. So after 65 years of age, all components of hypermetropia become absolute, because we have lost the ciliary muscle tone and we have also lost our power to accommodate. So whatever hypermetropia we land up at after 65 is absolute hypermetropia. This is the normal age variation which we see. So what are the symptoms of hypermetropia? The main symptom is blurring of vision for close work. Why does this happen? Because normally for close work we use our accommodation, correct? We use our accommodation to look at near objects. But in a hypermetrop, they use their accommodation to see distance. So they have already utilized all their accommodation. So when they try to do a close work, they are not able to do, and their main symptom is blurring of vision for close work. The symptoms may also vary depending upon the age of the patient and the degree of refractive error. A mild patient may be just asymptomatic. A small error never produces symptoms or may not produce symptoms because it is corrected by the accommodation of the patient. At times, when the refractive error cannot be fully corrected by the accommodative effort, the patient will give symptoms of defective vision. But if they are constantly able to correct the refractive error because of the accommodative effort, defective vision will not be a symptom. So what will be the symptom? The constant accommodative effort will cause asthenopia, that is sustained accommodation may produce symptoms as the day progresses because of the prolonged near work. So what do they feel? They will complain of tiredness, frontal or frontotemporal headache, photophobia, watering. All these are symptoms of asthenopia. The patient will not come to you saying I am having defective vision. So any patient who complains of fatigue and fatigue like symptoms, it is because of asthenopia. We have to look for hypermetropia. When the error is more than the patient is able to correct with their accommodation, this is when the patient develops defective vision. Here the defective vision will be more for near than for distance, and asthenopic symptoms will also be there because of the sustained effort of accommodation. Sometimes when the error is more, the main symptom will be because of the high error, and it will be only defective vision because the patient will not be able to correct his refractive error due to accommodation. So the main symptom will be defective vision, and as already told, the defective vision will be more for near than distance. Sometimes there might be intermittent blurring in youngsters because of prolonged accommodative effort may lead to accommodative spasm, because when they are having some exams they will be reading for prolonged period of time, or they are playing games like near vision, using their near vision, they will lead to accommodative spasm, and this can lead to intermittent sudden blurring. So we have already seen the symptoms. So what are all the signs? When you look at the signs, as I already told you, it can either be completely normal visual acuity or defective vision more for near work. If you look at the eyeball may be normal in size or small. The cornea may be flatter or it might be smaller because of microcornea. The anterior chamber many a times is shallow, but it is not a necessity that they must have shallow antechamber. The lens may be normal or posteriorly displaced in case of a positional hypermetropia. And A scan invariably shows a short axial length. Fundus we have, because of the small disc, we have what is known as a pseudopapillatus like picture. Because of the irregular margins and the crowded disc, we have what is known as a pseudopapillatus like picture. And because of the large alpha angle, there might be an apparent divergent squint like picture. And the blood vessels may show undue tortuosity, and the background retina, because of the curvature, may show what is known as a short silk retina. So what are all the complications of untreated hypermetropia? The patient can come with recurrent styes, chalasia, blepharitis. They can have, because of continuous accommodation, they may land up with a accommodative convergent squint. If it is not corrected, like any refractive error, they can go in for amblyopia, which might be anisometric, strabismic, because of the uncorrected hypermetropia. And these patients, as I already told you, they have small eyeball and shallow AC. They are more prone for primary narrow angle glaucomas. So what are the treatment modalities? The treatment, if it is small, the error is small, may not require treatment. If they are asymptomatic, they might not require treatment, because these are the patients who have been incidentally found to have hypermetropia. The visual acuity is normal, then it is patient is asymptomatic, again we don't treat. And if there is no muscle imbalance, again an asymptomatic patient exhibiting any of these symptoms, we don't treat the hypermetropia. So let's see what are all the modes of treatment of hypermetropia. So hypermetropia we can treat with spectacles, we can provide the patients with contact lenses, and if the patient wants to undergo surgery, there are surgical options available. Spectacles. So what are the advantages of using a spectacle? It is easy to wear, they are very comfortable, less expensive, and relatively safe. When it comes to contact lenses, they are cosmetically good, they give you an increased field of vision, provide less magnification. We know when we correct the hypermetropia, we are going to give plus lenses, so the inherent effect is magnification. So when you wear a contact lens, the magnification effect is slightly less when compared to spectacles. And also all the aberrations, the spherical and prismatic effect because of the glass high power plus spectacles is not present in a contact lens. Refractive error can also be corrected by refractive surgery, but for hyperopia it is not very commonly done as in the case of myopia. But if a patient insists on undergoing refractive surgery, it can be provided as an option for correcting hypermetropia. Now, American Academy has given us some guidelines as to when and how to treat. So, according to the American Academy, unless there is a ESO deviation or evidence of reduced vision, it is not necessary to correct low hypermetropia, because we know that hypermetropia is physiological in children and they have a very high amplitude of accommodation. And as with myopia, if hyperopia is associated with astigmatic error, they should be fully corrected. When hyperopia exists along with esotropia, then the initial management has to be a full cycloplegic refractive error correction. But if the child is not able to tolerate, then appropriate reduction in the amount of correction can be given. But when we deal with a school-aged child, a full refractive correction sometimes may cause blurring for distant vision because they are not able to relax their accommodation fully. So in such a case, we have to again give a reduced correction for a school-going children. Now again, the American Academy has given us guidelines as to when to interfere or intervene. So isoametropia. What is isoametropia? Is a condition where the refractive error is similar in both the eyes. So when there is a hypermetropia in both the eyes with no manifest deviation, the child is less than 1 year of age, then unless the power required is more than 6 diopters, we need not correct. Likewise, from 1 to 2 years, 5 diopters or more, 2 to 3 years, 4.5 diopters or more, and 3 to 4 years, 3.5 diopters or more. When hypermetropia is associated with esotropia, then we don't wait for a high amount of hypermetropia. We start correcting even when the hypermetropia is as low as 2 diopters. when the child is less than 1 year of age. 1 to 2 years of age, again 2 diopters or more. 2 to 3 years, 1.5 diopters or more. And 3 to 4 years, 1.5 diopters or more. Anisometropia without strabismus. Then hypermetropia has to be corrected if it is 2.5 diopters or more if the child is less than 1 year of age, 2 diopters or more when the child is 1 to 2 years of age, 2 to 3 years of age 1.5 diopters, and 3 to 4 years of age 1.5 diopters or more. Now when it comes to adults, if the symptoms of eye strain are marked, we correct as much of total hypermetropia as possible, trying as far as we can to relieve the accommodation. But when there is a spasm of accommodation, we have to correct the total error. Invariably, some patients with hypermetropia are not able to tolerate full correction. So, like in the case of children, we have to slightly undercorrect them. Likewise, a hypermetropic patient with exophoria should always be undercorrected by at least 1 or 2 diopters.